Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, I'm Tony Urbina, the Medical Director for CEI's HIV Primary Care and Prevention Center of Excellence. I'm a provider and a professor of medicine at the Icahn School of Medicine at Mount Sinai Hospital who has been working in the field of HIV for over 20 years. Research suggests that LGBTQ adults have higher rates of substance use and mental health issues compared to their heterosexual cisgendered peers. Furthermore, LGBTQ clients typically enter substance use disorder treatment with more severe problems, greater psychopathology, and greater medical service utilization. These health disparities are often related to minority stress or the chronic psychological and emotional strain that people experience due to being part of a marginalized social group. For example, some LGBTQ folks may use alcohol and drugs to cope with internalized homophobia or to self-medicate for anxiety and depression. On the other hand, some people use drugs in the context of social settings and connecting with others in their community. Since not all substance use is unhealthy, how do providers know how to identify when substance use is problematic? And what can physicians do to better support their patients who may be at greater risk for harm or even overdose? On this episode, our guest is Dr. Eric Kutcher. Eric Kutcher is an assistant professor of medicine at the Icahn School of Medicine, where he practices as a primary care and addiction medicine physician at Mount Sinai's Internal Medicine Associates and REACH program. He currently serves as the medical director of the Mount Sinai Hospital Opioid Overdose Prevention Program and primary care lead for the Mount Sinai Center for Transgender Medicine and Surgery. His clinical work and research focus on harm reduction techniques for patients with substance use disorders, particularly within the LGBTQ+ community. Dr. Kutcher and I talked about how providers can identify when substance use is a problem and how to help patients manage substance use disorder. As well, he walked me through the treatment options and the latest harm reduction strategies. I hope you enjoy listening to our conversation. Welcome, Eric. Thank you for joining us today.
Thanks so much for having me.
You're very welcome. Before we dive into the clinical aspects, could you share what drew you to focus on the intersection of LGBTQ health and addiction medicine?
Yeah, it's a good question. I've had a non-traditional path into medicine. When I was in college, I studied history of public health and African studies. And for both of those, really was looking at the history of the HIV epidemic and understanding its impact on people who were living through it and the degree of stigma and shame that a lot of people had and fear. And really, as I did a lot of research around that, I decided to go into medicine in order to work with vulnerable populations that were often misunderstood by the medical system and not necessarily treated with as much respect as they needed. And as I started my residency in medicine, I started to see that a lot of what I had seen in the history of HIV was what I was seeing a lot for people who use drugs in terms of that degree of stigma, shame, and mistreatment. And I decided to do my addiction medicine fellowship because of that. And then luckily get to mix my interests and passions for LGBT health and addiction medicine to be able to focus on a really important intersect of two vulnerabilities and populations that really need sensitive care. And I think in the community, we really don't necessarily talk about this as much as we should. I think there are certain avenues that people can go to in order to discuss their experiences, but I think that many people often feel like they're suffering alone in this space. And so that's why I decided to get involved in taking care of patients here.
Wow. Quite a background. It's so interesting that we share this commonality of HIV generating our interest in a lot of other issues that patients face. I do agree with you that really, providers don't talk about this as much as we need to, substance use. And I think part of the issue is that many providers really struggle with identifying when substance use is a problem and when it's not. Could you walk us through how you approach this spectrum?
Yeah, so I think that we all grew up in the era of like drugs are bad, right? I remember I had DARE when I was in like middle school, high school, and it was like all drug use is awful. And so I think that as doctors, we don't necessarily learn that much about substance use, and that therefore we think substance use is bad. And the truth is that isn't really necessarily true, that there is substance use that can be normal. There are real rational reasons why people turn to substances. So if you think about having a drink of wine on a Friday night, went out with friends, right? Like, we don't think of that as fundamentally a bad thing versus a reasonable way of unwinding, having fun, and connecting with other humans. And so I think that, first of all, point is that we need to make sure that we're assessing for why people are using their substances and making sure that we don't just assume that because people are using substances that it is problematic. And then once we find out that somebody is using substances, the question is, okay, so is it problematic? The first way is by checking to see if they are doing anything that puts them at risk to health. And usually that's trying to think about, is somebody binge drinking, for instance, doing something where they're consuming so much of a substance that it directly puts them at risk of bodily damage, like hepatotoxicity, right? Or drinking and driving, where they are doing something where we know that by combining activities and the substance that they are at risk of hurting themselves imminently. And so if they fit into that category, it's considered at-risk substance use. Again, not a substance use disorder, not an addiction, but just maybe we should counsel about safety in those areas. And then a substance use disorder really is made up by three main things. So that's cravings, control, and consequences. So cravings, meaning that you feel like you're having the need to have certain things that you can't really think of other ways to address either needs for pain or for anxiety or for depression. Controls that you try and cut down and you can't, that you have no ability to actually regulate the use in your life. And consequences is when you have things that are usually from either a social or health or otherwise impact on your body. That's going to be when you have, for instance, alcohol withdrawal and you have shakes and need to get admitted to the hospital, or when you have recurrent episodes of pancreatitis. And I'm focusing on alcohol here because I think it's one of the substances that many internists see the most and are most comfortable with. But once we think about somebody having difficulty with cravings, control, and consequences, that's when I start to really think, this person might have a substance use disorder. And the DSM outlines all the different criteria that usually will fit into these three buckets. And so from an internist perspective, those are the main things that I would recommend thinking about.
Yeah, wow. Thanks so much for that explanation. I was often thought of substance use disorder like just as a spectrum, just as you explained. So there's like use, abuse, and then addiction. And like addiction was like a brain event or a pharmacologic change, right? Where these cravings and all those things that you mentioned. But thank you so much for like breaking that apart for us. I've also noticed that you've worked across several major medical centers across New York City. What patterns have you noticed when it comes to substance use harms that are actually presenting in LGBTQ plus communities?
Yeah, I'm a New York lifer, so it's hard to get me to leave the island of Manhattan. But I think that to me, really what I've seen pretty universally is this fear and this need to really focus on building trust with patients. I think that a lot of doctors walk into the room and we take for granted that our patients should trust us. And I think that is not true for many patients, and particularly for this population. I think that it takes a lot of effort for these patients to show up, and that they've often had some trauma, fear, stigmatization, or otherwise negative encounters in medical settings. And so to me, really making sure that I put the extra effort in to build that relationship before I even start talking about the substance use is almost always key. And then I think the second one is really a lot of the times there's a focus on abstinence and this idea that any substance use is bad, and that if you have a substance use disorder that you could never use and you should never use, and that if you do use, that's a big mistake and a big issue. And I think it's a lot more nuanced than that. But I think that in the LGBT community, a lot of substance use is fairly normalized, and it is where a lot of people go to socialize and to gather. And so I think understanding that rates of substance use are higher in this community, and that's not necessarily something that always allows for easy abstinence, and that abstinence may or may not be our patient's goals. And so really listening to the patient, trying to prioritize their individual needs, and then trying to figure out how to best connect them to plans and to resources that address and hit those needs.
Yeah. What kind of training did you have to get to that point? And what do you recommend for other providers just in terms of having that attitude?
I think a lot of it is trauma-informed care and patient-centered care, right? Like I always approach every single patient as assuming that there is some trauma, stigma, fear that they have of the medical center, and I never take their trust for granted. So I think that in each patient encounter, I make sure that I put extra emphasis and extra time into the getting to know you part of the entire session before I even jump in. Because I think that otherwise, how are my patients going to trust me? How are they going to tell me the things that they feel like they can't necessarily tell other people? And so I really find that's one of the best ways of doing it, is just really trying to have a good small talk conversation with the patient and getting to know who they are before you even focus on the medical components.
Wow, really helpful. Shifting gears a little bit, but you talked about it a little bit in terms of treatments. So what treatments should frontline providers consider using in the office for patients with substance use disorders?
Yeah, so it totally depends on which substance use we're thinking about, right? And so first of all, we addiction medicine doctors are always here to help support you. And so I never want you to feel alone. There are great resources online. Hopefully you have referrals that you are able to connect with. And so recognize if you feel uncomfortable, that's fine. We're here to help and support you. But there are some really easy to use great options for some substances in general primary care settings. And so it's probably worthwhile jumping into some of those. I'd say the first really for alcohol use is naltrexone. So this is a great medication. It is a once a day medication that you take that it's actually an opioid antagonist. So it blocks the opioid receptor. Why does that work when alcohol doesn't work on that receptor? Actually, the opioid receptor is what is responsible for making you go from tipsy to drunk. And so it does indirectly work on the alcohol receptor on the opioid receptor. And the opioid receptor is responsible for much of the cravings in alcohol use disorder. And so when we blunt the euphoria you get from drinking and we get to get rid of your cravings, it makes a big difference. It's a very safe and effective medication. You can use it in most circumstances, really, if a patient has acute decompensated cirrhosis or has a concurrent use of an opioid, not a great fit, but there are a few other real times when you can't use it, and it's 50 milligrams daily. So it's pretty easy. If patients have concerns around taking a pill daily, there's also a really cool option of what an as-needed pill-to-pocket method. So basically where a patient can have a prescription for naltrexone, and then if they know they're going to go to some sort of situation that is going to be really hard for them to control their drinking, they take a pill. And it's been shown to decrease how much somebody drinks in those circumstances. That's a pretty easy intervention. If you have fancier things, you could do a once a month injectable version of that, but it's hard to coordinate. I don't think that many people on the outpatient setting without a real support team will have the ability to do that, but just know it's available. So alcohol, again, something that we see the most. I'd say opioids, it's worthwhile mentioning because I think we're in the middle of an opioid epidemic. Buprenorphine is an outstanding medication for that. It reduces mortality by about 50%. It is a very effective medication. The main thing is to ask patients if they're interested. If they are, there are lots of great resources about how you can start it. There's low dose initiations and traditional initiations. But honestly, most patients know how to start it. It's very rare that I see a patient who's coming in who has never used it before. So asking them how they did it last time, if it worked for them, and then filling the prescription is going to be key. There has been some changes in terms of what is allowed. And so the higher the dose of buprenorphine is usually better for both addressing cravings and preventing overdose. And so you could now get up to 32 milligrams of buprenorphine daily on most insurances. And again, I think there's a misperception by many PCPs about what dose do I want, what dose is good, like lower doses is better. That's wrong. We want you to be on as high of a dose of Suboxone as you need in order to decrease your cravings and increase your tolerance, honestly. The higher the dose of Suboxone, the better. Also available in an injectable version, but also really hard for you to do in a general primary care setting. So those are alcohol and opioids. I think stimulants probably is one of the things that really in our community is particularly important to focus on. And I think that the biggest group here is people like the party and play chemsex. I would say chemsex view. And this is often men who have sex with men or some trans individuals as well. And we have very few amazing medications for this. I wish I had a better answer for you, but I think that harm reduction is going to be a key part of it because we don't have great medications. But briefly, just to provide the options, the first one that I actually really is naltrexone injectables with Wellbutrin or bupropion. So why does that work? The naltrexone helps, again, with the opioid receptor. So it can have some degree of intervention on the euphoria pathway. And then the Wellbutrin can also help as an antidepressant and it can also help as a derivative of stimulants. So maybe with some ADHD and other components. This is, for me, fantastic because it prevents against opioid overdose. So right now in 2024 in New York City, about a third of methamphetamine and cocaine samples will come back positive for fentanyl, which means
Wow.
that there is a big risk of unintended overdose. And so injectable naltrexone makes it so that you basically can't overdose on that sample. And so that's why I love this treatment, is because
Wow.
of that part by itself. When I think about how good it is for actually treating methamphetamine use disorder, not as great. So in the main studies that looked at this, it was about like 14% of people who used the naltrexone injectable and Wellbutrin combination. So about 14% versus 2.5% of placebo responded to these with urine drug screens, really low. But again, it's an option that we have. And with the overdose prevention, seems like a decent one. And then the next and other main pharmaceutical option that we have is mirtazapine. And that at 30 milligrams has been shown among men who have sex with men in particular to help decrease the risk of use and focus on abstinence. And it's got a risk ratio of 0.67 to 0.75. So it's got, again, some degree of impact, but not amazing. And I think that it really does also help with depression and insomnia. So for people who have that as a primary component of symptoms that they're focusing on, then I feel like it's a decent option too. It's important to say the best treatment that we have, something called contingency management. It has over 20 studies that show great evidence that it helps decrease risk of use, encourage abstinence and negative urine drug screens, and reduce risky behaviors around sexual activity. And these are studies, some of them that look particularly at men who have sex with men. The idea is that you basically give rewards for not using drugs, and that you get like a raffle prize or gift card, something like that, when you give a urine drug screen that is negative, and you're engaged a lot in coming up with the goals around what you're trying to set for yourself often. And so it really is wonderful. It's just really hard to get funded. It's sad that we're in that place, and I don't think that it's a real option for most of our patients, but hopefully we can expand that moving ahead.
Wow, those are really a lot of options and really an enhanced toolkit for providers to use. I was curious with the intramuscular naltrexone, just because it is an intramuscular injection, what has been your experience using that in an outpatient setting?
It's great. Honestly, it's so great. Patients come in once a month, they get the injection. And I think the logistics around coordinating, getting it from the pharmacy, getting it delivered here, making sure that it's at the right temperature before we actually get to inject it, those are a pain. But I think that the truth is that for patients, when they take it, that's it for the next month, right? We've seen this in other medications with long-acting injectables. It is great when you don't have to worry about a medication every day, and also means that you come in more frequently to see me, and who doesn't want that? But it allows me to have ongoing check-ins and continuation of care in a way that a monthly prescription that you can get 3 months at once doesn't really necessarily do.
Yeah, no, I think that makes a lot of sense. So you spoke a little bit about harm reduction. So what harm reduction strategies have you found to be most effective with when you're working with LGBTQ plus patients who use stimulants?
Yeah, so I think that this really is the key of what I do, right? As I said, the medications work somewhat, but not really. They're not amazing. And so to me, my goal is to keep the patient alive and to focus on trying to improve their quality of life. And honestly, most of the time that comes down to harm reduction. I think harm reduction for LGBT individuals is like something that comes naturally to many of us. I think that our community was really involved in this, both in the substance use as well as the sexual health space since the 80s. And so I think the idea of trying to do everything you can to decrease the risk of morbidity and mortality makes sense to many patients. And the explanation isn't necessarily needed as much as it may be for other people. But as I said, my first goal is to keep the patient alive. And so what that means is right now trying to make sure that patients don't overdose unintentionally from fentanyl while they are using stimulants. And as I said, about 30% of our samples in New York City come back positive for fentanyl. That is in samples that people do not think are going to have fentanyl in it. So that's like people who go, they buy methamphetamine, and they don't know that there's anything else in there. That is terrifying because people aren't looking for it. And therefore, if they overdose, people don't know to suspect that there was fentanyl in the supply. And so therefore, they're not necessarily prepared to intervene with Narcan and naloxone kits the way that you usually would be. I always start by telling my patients and seeing if they are aware about the contamination of the drug supply in New York City and making sure that they know that there is something called a fentanyl test strip. So that's basically a little strip that you can use. There are a bunch available in New York and some other places as well, but that allows you to check for the presence of fentanyl in the supply. It's actually quite sensitive and specific, even in stones. But the key is if you are going to talk about fentanyl test strips, please make sure you review with your patients how to read it. I know this sounds crazy, but the test strips have the opposite way of being read as a COVID test. So if you have one strip, it is positive, which means there's fentanyl in the supply. If there are two strips, that mean like two lines, that means that it is negative, which means there's no fentanyl in the supply. And so I review that every time I give them out because I think that I don't want my patient to misunderstand the intervention that I'm giving. So the next big part of it is about making sure that they have Narcan kits and naloxone kits available. Usually you can get those either over the counter or with a prescription. And then here in New York, we've got 2 overdose prevention centers. So those are spaces that's called On Point, where people can go, they can use drugs and be monitored for overdose and for other complications. And so those are outstanding resources, have amazing evidence internationally to show a decreased risk of overdose and connection to care for substance use disorders. And so we should definitely be referring patients there. And then we talked a little bit about some of the pharmacologic ways that we can also help keep patients alive, which is with that injectable naltrexone and with medications for any coexisting opioid use disorder or anything else. And so that's the keeping them alive part, right? And then the next part is how do we decrease the risk of morbidity and mortality? And I think that the first thing is going to be about infectious disease. And so trying to make sure that we decrease the risk of both endocarditis, which a lot of our patients who inject drugs will have. So teaching them sterile injection techniques, reminding them how to use alcohol swabs, getting them access to a syringe service program or to other needle exchange programs in order to decrease the risk of Hep B, Hep C, HIV, all of those bloodborne illnesses. And then I think that that's one part, but also focusing on practices that tend to have less of a acute risk from a morbidity and mortality perspective. For instance, booty bumping, which is using methamphetamine per rectum, has fewer risks associated with it than an injection. And so that might be an option that patients would be willing to try. And so trying to help people move away from things that have the highest risk, which is going to be injection, to something like booty bumping. I'll also put in a comment about smoking, because I think that smoking is probably one of the most addictive ways of consuming a drug. And so I would never encourage a patient to go from injecting to smoking, because it actually will make it really much harder to treat their underlying substance use disorder and comes with a lot of cardiovascular risks from stimulants. So I wouldn't do that. But booty bumping is a good, a good recommendation. And then I love telling my patients to set reminders on their phones. Can they put an alarm to go off when they are having a party and play weekend, right? And they make it so that they remember to take their HIV meds or their PrEP or something else. Because the truth is that is a huge component of harm reduction, right? And I will tell them, like, make sure that you have certain alarms that are set that go off every 5 minutes for a certain amount of time until it annoys you enough that you use it. And that can be really helpful. And then I think a lot about the sexual side related to these chemsex parties and party and play. And some of that is really about just general reducing pain, discomfort, and optimizing sexual health. That's going to be providing lubricants, condoms, access to doxypep. I think that's really key. And then if people are in areas where they are sharing like douches or other supplies, having the ability to disinfect those is usually a good option too. And then the last real thing, so when we think about methamphetamine and its risks to the body with recurrent use, is dry mouth is a huge problem.
You're right.
People get really bad teeth and also very dehydrated. What I really recommend is making sure that people have access to something that keeps them hydrated. So sometimes sports drinks is part of that, having access to nutritious foods. And then one of the really great options is providing gum. So if somebody has gum, then it helps them not grind their teeth, helps their mouth a little bit moister, and can be a really good option too. Those are some of the harm reduction options that we have. I think, again, how comfortable each individual primary care doctor is in providing these is understandable. And there are great resources that we can definitely make sure that people have access to. But I think that there's a lot of LGBT-focused harm reduction resources that exist. So.
Wow. That was a really great and comprehensive review of kind of strategies that we can take and just information that we can give to our patients. And I'm sure they're truly appreciative of it as well, right? And you do sit down and give them the time explain. And
Yeah. I think honestly, like when I talk to my patients about harm reduction, I can't tell you how often they appreciate it because like they're being seen and heard and not being told that they have to be abstinent. And almost always after I finish a conversation around harm reduction and how to make sure that people are safe when they're using drugs, a patient usually will say, okay, so is there anything else that we should be talking about? And like really opens up to all sorts of conversations about whether it's PrEP or whether it's medications for substance use disorders or something else. I just think that it shows that you genuinely care about the person, that you don't have an agenda other than to keep them safe and alive. And I think that that is something that we can always agree upon, right? Me and any patient.
Yeah. No, super important. So Eric, looking to the future, where do you see the field of LGBTQ plus addiction medicine heading in the next few years?
Yeah, I wish I could perfectly predict. I think that the truth is the same way that with PrEP, we are having injectables that become more and more accessible. With substance use disorders, particularly around opioid use disorder and alcohol use disorder, we have really great long-acting injectables. They last about a month. And it's not as long as what we have for some other conditions. But I think that Brixadi and Sublocade are injectable versions of buprenorphine that really basically it can be a vaccine for opioid use disorder for a month, right? Naltrexone, an injectable, like the injectable version is called Vivitrol, that basically can serve as a vaccine against alcohol cravings for a month. I imagine that as we look forward, there will be a little bit more of the ability to combine long-acting treatments for both substance use disorders and for PrEP and for HIV treatment in the same space. I think right now they're quite siloed. And I think that being able to integrate and provide the care to patients at the same time will make a huge difference for quality of life and really be able to get patients engaged in care for multiple components of their overall health in the same place.
Yeah, I think that makes a lot of sense. Yeah, because we're seeing that just right in the field of HIV, just with longer acting PrEP agents. I think lenacapavir will be approved next year. So subcutaneous injection every 6 months. So why not combine that with, makes a lot of sense. Okay, so just final question here, Eric, just what's one piece of advice that you give to kind of frontline providers who want to better serve their LGBTQ plus patients who use substances? I think you've touched on a lot of these, but just final word on this.
Yeah, I think honestly, like patients use substances for real reasons, right? If it's a person who's using methamphetamine to stay awake when they're homeless, or if it's a person who's using it to be able to engage in sexual activity because they feel stigmatized and have a hard time with sex and sexuality otherwise, or it's because they've only ever had sex while they're on methamphetamine, so they don't know how to have sex anyway, right? Our patients are usually using drugs for a reason. And so having empathy around it and trying to figure out what is it that you learn to use drugs for? And recognizing that there is a rational reason. This isn't a person's choice. This is something that they have learned as a coping mechanism, and that we can help them figure out other ways of coping and dealing with issues that they have that maybe are healthier for them. But I think that when I go in to see a patient, it's always about how can I help you, and coming in with a real sense of empathy that this person is having a hard time and that I don't know what they need. They know what they need best. And so together we can partner to figure out what solutions will hopefully make their life better.
Yeah. So thank you, Eric, for joining me in this conversation today. Your insights on caring for LGBTQ plus patients who use substances really are not only practical, but also deeply compassionate. And I'm really hoping that our conversation today will help providers deliver better and more compassionate care. So thank you, Eric.
Yeah, thanks so much for having me. A pleasure.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.